Okay, so as Rebecca said, I'm here today to talk to you all about how we're measuring pediatric CT dose through the Leapfrog Hospital Survey. And if you haven't heard of Leapfrog Group or the Leapfrog Hospital Survey, that's totally fine. Hopefully you'll be knowledgeable about that by the end of the presentation. So first, I just wanted to introduce myself. So I'm a program manager for the Leapfrog Group, and I'm on the healthcare ratings team. So I focus specifically on the Leapfrog Hospital and Ambulatory Surgery Center surveys, including data collection, public reporting, development, and maintenance. And I'm coming to you tonight from Charlottesville, Virginia on the East Coast, a couple hours south of Washington, D.C., which is where our offices are located. And again, I'm just really happy to be here, excited to talk to you guys about the Leapfrog Group and how we collect data on CT dose. So thanks for having me. So our agenda for today. So we'll give you background about who the Leapfrog Group is, what is the Leapfrog Hospital Survey, and then of course we'll go into the measure specifications for the pediatric CT dose measure, and then talk about how Leapfrog verifies those data. We'll also talk about how Leapfrog assesses performance on this measure, and how those results, of course, are used for quality improvement. And then we will have time for Q&A, as I understand it. So diving right in, the Leapfrog Group is a premier purchaser-driven nonprofit. We were born out of the movement for healthcare transparency. We were founded by purchasers in 2000 in response to the IOM report to Err is Human. Our mission is to trigger giant leaps forward in safety, quality, and affordability of U.S. healthcare by using transparency to support informed healthcare decisions and to promote high-value care. So we're really driving change by empowering purchasers and consumers. We're used by national and regional health plans, employers, transparency vendors, and of course, consumers. I've added the link here to our website. It's just leapfroggroup.org if you wanted to take a look or wanted any more information about who the Leapfrog Group is. Next, what is the Leapfrog Hospital Survey? So the Leapfrog Hospital Survey is completely free based on voluntary submissions. It's an annual survey that's open to all U.S. hospitals from April to November every year. The survey assesses hospital safety, quality, and efficiency based on national performance measures that are of specific interest to healthcare purchasers and consumers. Survey results are publicly reported for free on our website that I just linked, and provide hospitals with information to benchmark their progress in improving the care they deliver, which you'll hear me talk about throughout the presentation. Annually, we have over 2,300 hospitals, very proud of that number, from all 50 states, including military treatment facilities that submit a survey to us. And if you'd like more information about the Leapfrog Hospital Survey specifically, the link for that is there as well. So why does Leapfrog care about pediatric care? So employers and purchasers are paying a lot for pediatric care. Pediatric patients actually make up almost 16% of all hospital care in the US, which is nearly 5.5 million hospital stays per year. 43%, of those hospitalizations are paid for by private payers, which are the employers and purchasers that Leapfrog represents. The rate of cost growth in this age group is more than 3 times that of any other age group. However, there's little information, and we find this to be the case a lot of times, little information publicly available to compare the quality of pediatric care in hospitals. This is a problem. Leapfrog's employer and purchaser members want more information on quality of pediatric care to inform benefit decisions. Leapfrog Hospital Survey actually includes several pediatric care measures. So of course, the pediatric CT dose measure, which we'll talk about today. We also ask about the CAPS Child Hospital Survey, which is a patient experience measure. We collect data on hospital and surgeon volume for NORD procedures, which is a procedure on infants that have a particular congenital heart defect. And then we also collect volume for pediatric outpatient procedures. We collect data on quite a few of those. If you're interested in any of that, again, you can find more information on our website. But for the purpose of time, we'll move on to pediatric CT dose. So why do we care about pediatric CT dose? Radiation dose is simply a safety and quality issue. So because radiation doses for CT scans are so much higher than that of X-rays, Hospitals really need to pay attention to exposure, especially in these smaller patients, so typically pediatric patients. Radiation dose has been linked to cancer risk, and studies suggest that lowering the average dose in children would reduce the number of cancer cases in the US by 43%, which is the equivalent to preventing over 4,300 cancer cases per year. Okay, so now that you have some background, we will dive right into the measure specifications. So as Rebecca mentioned, this is an NQF endorsed measure, and we've asked about this measure since 2017 via our Leapfrog hospital survey. And we ask any hospital that performs pediatric CT scans to report on this measure. So what does NQF endorsement mean? NQF endorsement means that the measure has been tested for reliability and validity, and that it's been approved for use in public reporting and payment programs. So as we've said a couple of times, this measure was developed by Dr. Rebecca Smith-Bindman, who you all are familiar with. And it provides a framework for hospitals to assess pediatric radiation doses, compare themselves to national benchmarks, and use that benchmarking information to make adjustments to their doses and protocols as necessary. The measure assesses radiation dose for 5 age strata and 2 anatomic regions, which you'll hear me talk about a lot more as we get into the specifications. Head and abdomen pelvis are those 2 anatomic regions. And right from the front, just addressing some early feedback that we've gotten on this measure. So 3 main issues that we've gotten feedback on. The first being patient size versus patient age. So a lot of hospitals, radiologists, physicists would like to use patient size instead of patient age. But in order to standardize data collection across reporting entities, age is used in place of patient size. So patient age is more readily available and standardized than measures of patient size like height, weight, diameter. Age is also used for a surrogate, used as a surrogate, for patient size in various US and international radiation dosing guidelines. The next issue being dose versus image quality. So does reducing dose impact image quality? Studies suggest that image quality has very little degradation over a large range of dose variation, which means that there's often opportunity to reduce radiation dose while maintaining that diagnostic image quality. And the benchmarking information that we make available to hospitals can be used to assess internal protocols and make adjustments as necessary. The last issue being anatomic region specificity versus standardization and comparability. So we recognize that the anatomic areas that are included in the measure may be crude. They include many subatomic areas, but we need a standard category of commonly performed scans to ensure that the data we collect can be used for comparison for that benchmarking. So the real details of the measure. So the reporting period is 12 months. And as I said, the types of scans that are included are head and abdomen pelvis scans, and both inpatient and outpatient. So those 5 age strata that I mentioned that we look at are less than 1-year-old, 1 to 4 years old, 5 to 9 years old, 10 to 14 years old, and 15 to 17 years old. And for each of those age strata, hospitals have to have at least 10 encounters in order to report on those age strata. The unit of measurement that's used for this measure is total dose synced product per encounter. So we don't have hospitals report on individual scans. We have them report on encounters. So encounters are defined as exams performed on the same patient and the same anatomic area within a 1-hour time period. DOPs are standardized to 32 centimeters for abdomen pelvis and 16 centimeters for head exams. We exclude scalp doses. We also exclude biopsy exams, any encounters that across multiple anatomic areas, and exams where age is missing, of course. For head scans, we also ask that exams involving facial bones or sinuses are excluded. So hospitals will use the total DLP for a minimum of 30 encounters per age group. And then hospitals will use that data to calculate and report the 25th, 50th, and 75th percentile for each of those 5 age strata and 2 anatomic regions. So hospitals that are collecting the data manually for this measure can report on a sample of at least 30 encounters per age strata. But there are two other data collection methods where hospitals are required to report on all exams, all eligible exams. So just a little more information about those data collection methods. So hospitals that participate in the American College of Radiology's National Radiology Data Registry can use a Leapfrog specific report that's generated by ACR. Very nice report that those hospitals can use and is readily available to them to report to us. Hospitals can also use dose monitoring software, and many hospitals do go this route. So we've seen reports from places such as Landauer, Radiometrics, Analogic most recently. And they can use that to generate reports that align with the measure specifications. And then I also mentioned that hospitals can use manual data collection and report on a sample of scans. So in addition to asking about the NQF endorsed CT dose measure, Leapfrog also does look at emerging topics in pediatric CT dose. So Leapfrog has a collaboration with the American College of Radiology, and they provide us with subject matter expertise, and they advise us on emerging topics in pediatric CT dose. So most recently, in the last couple of years, we've been fielding on the hospital survey a series of fact-finding questions to learn more really about the processes and structures in place in hospitals that are contributing to safer doses. And that includes CT machine manufacturer and the age of that machine that's used for pediatric CT scans, and whether the hospital has established protocols for pediatric CT scans, the frequency of which they review those protocols, and who on the team is involved in reviewing and updating those protocols. And like I mentioned, this information is for fact-finding. It is not a part of the CT dose standard. So now that you know about the data that we collect, one question that always comes up is how we make sure that data is accurate. So our survey results are publicly reported on our website, as I mentioned, and they're used by many different groups in very important ways. So they're used by purchasers, consumers, health plans, transparency vendors, researchers. So the accuracy of the data that we publish and distribute is of utmost importance to us. So we have several protocols in place to verify the accuracy of our results. And we do this for all measures on both of our surveys. So not just pediatric CT dose. So the first and most simplest way that we ensure data accuracy is by having hospital CEOs or the CEO's designee completing what we call an affirmation of accuracy. And it's literally a legal statement that they have to sign and date that says that they are being truthful and that they affirm that their data is accurate. The second on the list are warnings in the online survey tool. So hospitals use an online tool to actually submit data to us. So they'll go in and enter their CT dose data there, and then they'll fill out this affirmation of accuracy. And in the background, we have thresholds. We run analyses of different sections, things that don't make sense, lots of different ways to assess the data for potential inaccuracies or errors. And the online tool automatically pops those warnings up so that hospitals can review them while they're there submitting data. The third bullet item, extensive monthly data verification, is sort of an extension of that second item. So we do a lot of that review automatically in the online survey tool, which is really nice. But we also do just as much external from that online survey tool, and we email out data verification messages to hospitals every month. So every month when we are assessing performance and publishing scored results for hospitals on our website, we do this as well. So I personally do this, and we have a great team of people who are doing this. And we look at high and low thresholds and just really anything that might be an error. A great example that I like to use is we ask about ICU physician staffing. And if someone says they do it in one place and then they say they don't have an ICU in another place, that's obviously an error. So that's something we point out to them and have them correct. And then the fourth bullet point down, monthly documentation requirements. So this is a bit more in depth where we actually randomly select hospitals. And for random measures, we will ask them to literally submit documentation to us. So whether it's for a protocol they have in place or policy in place, they'll submit that document to us. For pediatric CT dose, we oftentimes are looking at the dose monitoring reports, and that's why I'm pretty familiar with several of those dose monitoring report vendors, because we review a ton of those, just to make sure that data is accurate. Then we also have virtual data verification, which we've been doing since COVID began. Obviously, we haven't been able to go on site in hospitals during that time, but we're really excited that next year we're hoping to get back on site to do on-site visits in hospitals. So we send a team literally on site, and we have several measures verified right there in the hospital. All right, so how do we assess performance on this measure? So a little bit in general about how Leapfrog assesses performance for the hospital survey. So we score hospitals against national standards that are developed by national technical expert panels. Criteria to achieve our standards for each measure is always publicly available on our website. So we make scoring information available to hospitals, to the public, every single year for them to be able to know exactly how they'll be scored. So a lot of times for relatively new measures, such as pediatric CT dose, we often use a peer comparison methodology where the benchmarks are set based on reported hospital performance. So in this case, the two benchmarks that we use, which we'll talk a little bit more about, were established based on hospital performance that was reported on the 2021 Leapfrog Hospital Survey. So we use a median benchmark, which is the median of all the medians that are reported by hospitals. And then we also use a 75th percentile benchmark, so the median of all 75th percentiles reported by hospitals. And just a reminder that hospitals are reporting that total DLP per encounter. So the medians represent the 50th percentile for all of their DLPs per encounter. So hospitals are receiving points for this measure based on how they perform, how their median dose looks compared to those benchmarks that I just talked about. So if a hospital is reporting a median dose that's less than being better than the median benchmark, then they're receiving the most points possible, which is 2 points. If the hospital's reported median dose is between that median benchmark and the 75th percentile benchmark, then they receive 1 point. Otherwise, they receive no points for that age group. So this comparison is done for all age groups. This will be a little bit easier to see in the next slide where I have a screenshot of our scoring algorithm. It's a little tricky to picture it this way, but the comparison is done for all age groups and for both head and abdomen pelvis scans. So for each anatomic region, there's at most 10 possible points across 5 age groups. So if they do well on 4 out of 5, then they would get 8 out of 10, for example. And then the total points out of the total possible determines their performance category. So again, just as a reminder, some hospitals won't have a high enough sample, which is 10 encounters for an age stratum. And if they don't, that age stratum is not included in scoring. It's not used against them in any way. It's just dropped from scoring. So then their total possible points would be 2 times however many age stratum they have enough cases to report on. And here's a table that makes it a bit easier to look at. So at the top, so it's by the age groups that I've mentioned and the anatomic areas that I've mentioned. At the top of each table, you'll see that median benchmark. So if they're doing better than, or if the dose is lower than that median benchmark, then they receive the full points for that age group. And just a note, so we commonly freeze benchmarks for at least 3 years. And for this one, this is the 3rd year that we've had these benchmarks. And the reason for that is, like I keep saying, we really want hospitals to be able to see their performance improve over time. So if we were to change benchmarks every year, they wouldn't be able to do that very effectively. So these have been frozen so hospitals can really use this for benchmarking. And then as I described, based on the total possible points that the hospital achieves, a percentage is calculated, and then they fall into a performance category, which I'll talk more in depth about once we talk about public reporting. So how are these results used for quality improvement? Public reporting. So our public reporting website is ratings.leapfroggroup.org if you want to check it out. I'm going to show you some examples here today. But survey results are publicly reported and used for many important things. So they're publicly reported to educate and inform employer members and enrollees about patient safety and the importance of comparing provider performance on safety, quality, and resource standards. They inform employer, purchaser, and payer contracting decisions and value-based care strategies. And Leapfrog actually has a value-based purchasing program that's really great and uses survey results and is licensed by some health plans. It's also used to aid consumers in their decision about where to receive care. And we love hearing from consumers who are using our website. We get questions quite a bit. Great to see that. And it's also to allow for hospitals to benchmark, as I've said many times, and compare their performance. So as promised, a little bit more information about what we mean by performance categories. So we have 4 main performance categories for hospitals who are able to report on a measure. So there's a screenshot here at the bottom of what is often referred to as cell phone bars. So the top being the highest achievement, or what we call achieve the standard, which is displayed as 4 filled bars. The next tier being considerable achievement, which is displayed as 3 filled bars. The third category being some achievement, displayed as 2 filled bars. And the last category being limited achievement, which is displayed as 1 out of 4 bars. So we find that these cell phone bars make it is an easy way to visualize performance on the measure. So we do have a few additional scoring terms that we use that I want to make you aware of. So we use a term does not apply. So if a hospital, for example, doesn't do pediatric CT scans at all, they'll be publicly reported as does not apply. So we want hospitals to submit data to us, so we don't want them not doing or having a certain service line to prevent them from submitting. We also have a category called unable to calculate score. So this term is used for hospitals that don't meet a minimum sample size. So for pediatric CT dose, as I said a couple of times, if they don't have 10 encounters for an age stratum, that's not used in scoring. So for some hospitals, they won't have 10 encounters for all of the age strata for both anatomic areas. So they would be publicly reported as unable to calculate score. So we want to recognize them for submitting data to us. However, they didn't meet that minimum sample size, so we publicly report them as unable to calculate score. Decline to respond is the term that we use for facilities that don't submit a survey at all, or if they don't submit certain sections. So if they didn't submit the CT dose section, you would just see a big decline to respond on the website, which we will look at some examples. And then lastly, pending Leapfrog verification is going back to those data accuracy efforts that we have in place. This is really used for facilities who are undergoing that verification process, haven't yet completed that verification process. So we do sometimes report facilities as pending verification until we're able to verify their data. So this is what our public reporting website looks like. This is the search engine, which I think is really great, especially from a consumer point of view. So we have several different options for searching. So you can search by a specific facility name. If you have a local facility you like and you want to look up how they're performing, you can type the name right in there. We also have a location search. So you can search by your zip code, your city, your state, whatever you're interested in to see hospitals in your area. You can also search by procedure type. So if you're going to the hospital to have a total knee replacement and you want to see if they do well in that measure, you can look up just hospitals that perform that procedure. And then we also have a guided search, which allows you to search by particular measures. So for example, if you wanted to see pediatric care, you can search for those that report on pediatric care. And here's an example here of what it looks like. So you'll search and then all the facilities that have the data you're looking for will pop up. And then you're able to compare those, which is really nice. So this is an example of what the comparison looks like. So you can see these 3 hospitals results right next to each other. And in this screenshot, I pulled up the radiation dose measures. So you can see what those look like. You can see the performance categories there and how you can easily see what the performance looks like and compare it using those cell phone bars as well. And then this screenshot here, I just wanted to show you what an individual hospital's CT dose results look like. So again, we have that performance category there, but we also have those cell phone bars. So if someone's not familiar with the performance categories, you can still gather what the performance looks like from looking at that graphic. And you might notice that the language that we use here is a little bit different. So our website is consumer focused. So we do try to use consumer-friendly descriptions and names here so that someone that might not be working in a hospital or a clinician can get a better understanding of what it is we're reporting. Okay, so how are hospitals actually doing? So we recently did an analysis of data from 2021 to 2023 using the most recent data we have, which was as of August 31st. So the number of hospitals that report on pediatric CT dose is increasing, which is great, very exciting. That means more hospitals are voluntarily reporting these data and will have more information available for use. So in 2021, we saw 1,806 hospitals reporting on this measure. That was about 49%. In 2022, we went up 1% with 1,878 hospitals. And year to date, 2023, we have 1,648, which is 44% so far. However, our survey is open and we expect lots of submissions all the way up until we close on November 30th. So excited to find out what that final data will look like. And we've also seen hospitals show improvement in their performance on abdomen pelvis scans, but not in head scans, unfortunately. So we'll look at that a little closer. So this chart is showing the change in mean doses over time. So we looked at the mean of those medians that are being reported to us. And you can see that for head scans, it's not changing very much. So we would like to see a bigger change over time, and we just haven't for head scans. And the next slide is another great representation of how we're not really seeing what we'd like to see. So as I've said several times, again, we want hospitals to use this benchmarking information to adjust protocols as needed and to do better. But we're actually for head scans seeing that less hospitals are achieving the standard. So this green bar is how many or what percent of hospitals are achieving the standard out of those that reported on the measure. And unfortunately, it's gone down. Oops, sorry about that. It has gone down for head scans, which was really interesting to see. So for abdomen pelvis scans, a little more positive. We're seeing more of a trend. So we're seeing that doses have gone down for those top 4 age categories. Not so much for less than 1. Less than 1 is an outlier there. And then, of course, that corresponds with this graph well, showing that we have more hospitals, a higher percent of hospitals achieving a standard, which again is that green bar. So that's going up and that's great. Love seeing that. And that is all I had today. Again, thank you so much for having me. Was very excited to be here. Thank you so much, Rebecca, for inviting me. My understanding is that now we'll have a moderator come on to do Q&A. So I'll go on mute and look for that person.
I think what you mean to answer questions?
Yes.
So I think there's one question in the chat. I just want to say, I hope people can appreciate how incredible this program. You can't fix something until you measure it, which is really the whole basic premise of Leapfrog. And I think it's really exciting that you have been able to measure this in so many hospitals. Hats off that the doses have come down for abdomen. I think in general, there's much more opportunity for doses to come down in abdomen than there is opportunity in head. So it's still disappointing that the doses haven't come down, but we're not sure that they have to come down very much if they're at the right level to begin with. So the reduction in abdomen is really awesome, and I think terrific. I wonder what kind, the question reads, of feedback, positive and negative, you've received from hospitals as to whether they have found this information useful. Have you heard from the pediatric radiology leadership groups and about whether they believe this information is useful and impactful? Is that a question that you think you can?
Sure.
Yes.
So we actually have a great help desk. So we're getting feedback all the time And I personally am on there a lot. So we are getting feedback all the time about all the measures on our survey, and all of our programs. For pediatric CT dose specifically, I think the feedback that we mostly get are those three items that we talked about in the slides. Specifically the age versus size comment. We hear that a lot. Usually after we go over the information we went over today, that kind of resolves their concerns around that. We don't actually, we don't talk to radiology leadership too much. The only time that I've talked to radiology leadership is actually when I have to review documentation and I'll get on the phone with them. And we do hear that they find this useful as far as establishing and reviewing those protocols and looking at dose reduction if necessary in their hospitals. And a lot of hospitals, or most hospitals that I talk to, do take Leapfrog really seriously. So they do use this information to improve processes, not only for pediatric CT dose, but for all of those measures where we have established standards.
Fantastic, thank you. The next question is, what do you think is the reason why the dose for the abdomen pelvis scans less than 1-year-old group has gone up?
I think that when we looked at this, we talked about the fact that we're having more hospitals report every year. So it could just be a virtue of we're getting more hospitals in there, and the newer hospitals, maybe because they haven't looked at this benchmarking before, they're performing lower than hospitals that have been in this group for a long time. So that might have an impact on those data. But I myself haven't really dived in. That would be a really interesting question to dive into and look at more. So
I agree. I had the same thought. You would expect the early adopters, you have many early adopters, but might be at the higher quality end than later adopters. And so you're not measuring exactly the same group of hospitals over time. In fact, the initial ones might have the highest quality. It's hard to know. It's not a very big group, obviously. Thankfully, we don't do that many CTs in the youngest children. Someone's asked if Leapfrog is planning to align with CMS standards for benchmarking image quality. I think I have an answer in there, but I'm not sure if you have any work in the plans for doing so.
We don't, not to my knowledge. So for this measure specifically, we really are just collecting data based on that NQF endorsed measure as I described, and then just using the peer comparison benchmarking information right now for hospitals.
I think the answer that I was thinking is the CMS has adopted an adult measure that was also endorsed by the National Quality Forum that I mentioned earlier that does measure noise. There isn't a comparable measurement in children. Our group at UCSF is thinking about developing a measurement in children, but because of the way Leapfrog collects the data, they don't actually look at the images. They have manual submission of data. It would be very tricky to have a uniform measure of image quality unless the manufacturers adopt that measure and begin reporting it. It would have to be a number that they could collect, and currently that just doesn't exist. There's another question about how many different hospitals are each of the different performance categories. I think you showed us that maybe at the end, at abdomen in current practice, it's sort of around 50% are doing the highest quality group.
Mm-hmm. I think that my slides will be shared. If I need to add anything to those, please let me know and I can resend them. I don't know if I included the exact number. I think I included a percentage, but if folks would find it useful to have an exact number, I'm happy to add that and send out.
Fantastic. There's a question I don't exactly get, but maybe you'll get it. It says how Leapfrog can get those hospitals involved in the survey. I think the question is how do you encourage hospitals to participate?
Sure. So I think a lot of times, just by virtue of Leapfrog is widely known, and consumers look at our website, health plans use our data, hospitals are very motivated by that in itself. So people are really looking at the information that's on our website and using that to make decisions about where to receive care. So that influences hospital in and of itself. We also work with what we call regional leaders, and those are typically business coalitions, statewide business coalitions, and they really are on the ground folks. So we are we're a pretty small company, so we look at our regional leaders to really talk to hospitals and to really give them reasons to participate in our survey. And that strategy has gone great. So we have got a lot of great relationships with those regional leaders, and those regional leaders have great relationships with many hospitals. And the number of hospitals participating continues to grow each year, which is really exciting.
I believe that there are some hospital groups, there are some hospitals that work on their own, and there are some hospitals that are part of large networks. I know some of those networks require their members to report on Leapfrog quality measures. They believe that it's quality. And so it's not a decision that's necessarily made at the level of the individual hospital, but rather at the larger organizational level.
That's a great point. That's definitely true.